Hi, good morning, everyone. I'll be speaking on management of brain metastasis in lung cancer with respect to radiation therapy. My talk will be on basically the management of brain metastasis, for example, with respect to WBRT, SRS or cavity SRS, and then the multifractionated SBRT or SRT. So as you can see here, I love this topic of brain metastasis in lung cancer because if you see the evolution of brain metastasis research, so with respect to radiation therapy, it has gone in a very systematic manner. Previously in 1980s or 1990s, where none of the systemic therapy were available, especially for lung cancer, then we used to deliver whole brain radiation therapy. So we have the randomized data for whole brain radiation therapy also, and then subsequently, as you will see in my future slide. So as far as the disease distribution is concerned, the lung cancer contributes to approximately 20% of overall incidence of brain metastasis in oncology population. There are cases in melanoma, RCC, breast cancer, and the colorectal cancer, but lung cancer constitutes the most common cause of brain metastasis in oncology. So why do we see more cases of brain mets? There are a significant development and efficacy of the systemic therapy nowadays, especially, and there are better imaging modalities which are able to pick up the asymptomatic lesions also. So we are seeing more and more number of brain metastases. As you have heard that Dr. Nandini has said that we have started using to do the MRI brain at baseline, so it will detect the asymptomatic brain metastasis because the patient is not symptomatic. Unless and until the patient is symptomatic, you are not going to do the MRI brain. So these are the index of radiosensitivity that you have in the primary tumor. The lung is moderate, but if the lung is of small cell, high index of radiosensitivity because they are more sensitive to radiation therapy. Now, about the site distribution, the cerebral hemisphere constitute approximately 80% of the location of the brain metastasis. Now, but the cerebellum 15% and brainstem is 5%. If the patient is having metastasis in the brainstem, then it's a difficult area, and the patient can go from PS0 to PS3 or 4, or even death in a very short span of time. Now, coming to the diagnosis, you must have heard about the diagnosis and the radiological finding of brain metastasis with respect to Dr. Prakash Shetty presentation. The clinical features are important. The general symptoms are the headache, the sensory motor deficit, neurovascular deficit, the seizures, the cognitive and behavioral abnormality. You can actually detect the location of the brain tumor or brain metastasis, so depending upon the clinical signs or symptoms. If the patient is having a tingling or a left arm weakness, then most probably the patient is having a brain metastasis in the precentral gyrus of the brain. So you can actually detect the location of the brain metastasis with respect to sign and symptoms. The focal symptoms could be hemiparesis, the gait imbalance, aphasia, and the visual field deficit. The patient can be asymptomatic also. The imaging features, MRI is the investigation of choice rather than the CT scan. The solid ring enhancing lesion, the pseudo-spherical multiple gray-white junction, where the blood vessel decrease in diameter, it acts as a trap for clumps of tumor cell. The differential diagnosis could be abscess, any infection, the demyelination disorder, or the primary brain tumor. So these are the prognostic indicators. So because there are multiple brain metastases, if you see a normal patient with brain metastasis who is coming to your clinic, he might be having a various amount of sign and symptom, and the performance status can go down. So if the patient is coming on a stretcher bound, so you will see, so what is the point of treating a patient who is stretcher bound? Let him go home and just do the steroids. So there are prognostic indicators available. For example, RPA. RPA is the recursive partitioning analysis. So RPA class 1, RPA class 2, and RPA class 3, so which will give us an indication. RPA class 3, if we can see, it's only based on the performance status. If the Karnofsky performance status is less than 70, it is considered to be RPA 3. And the median overall survival will be approximately 2.3 months. So that means approximately 70 days and not more than that. If the patient is of RPA class 1, the median survival can go up to 7.1 months. Okay, so what is RPA class 1? The KPS should be more than 70, A should be less than 65, the primary tumor should be controlled, and there should be no extracranial disease. And if there is for example, if there is a single brain metastasis, it can go up to 13.5 months. So with the help of partitioning analysis or the prognostic indicator, you can triage the patient of how you want to treat those patients. Now, these are the other prognostic indicators which have come in 2008, 2012, and 2017 as we move forward. So with respect to systemic therapy, so GPA is the graded prognostic assessment score. The DSGPA is the diagnosis specific. So there are lung cancer, renal cancer, breast cancer. So diagnosis specific GPA. And then the lung molecular GPA, where they have involved the EGFR mutation, EGFR or ALK mutation in this in this score also. So as far as the general management is concerned, you must have heard the symptomatic is the best management. First, the vasogenic edema, seizures, or DVT. For the vasogenic edema, you can use the steroid to reduce the edema. For seizures, there's no role of prophylactic anti-epileptic drug. Okay, so if the patient is having a seizure, then you should start uh, anti-epileptic medication. The DVT prophylaxis, so because this patient can be wheelchair bound or stretcher bound, then you need to consider for the deep venous thrombosis prophylaxis. Specific treatment directed to the brain metastasis should be considered, and the systemic therapy. Now, the management of brain metastasis with respect to all the number of brain metastases. First one is the surgery. You can do the SRS or SRT, whole brain RT, hippocampal avoidance WBRT with simultaneous integrated boost, and the optimal supportive care. Now, if you see the literature, there is a problem of plenty. In brain metastasis, we have a whole lot of number of trials and the treatment regimen. For example, whole brain RT alone. For example, surgery alone, SRS versus surgery, and the surgery followed by the post-operative WBRT. So in the first few slides, we will consider about the whole brain radiation therapy alone, the surgery alone, or SRS versus surgery, or surgery followed by post-operative WBRT. So this was the first randomized control trial which was published in NEJM in 1990. So they have considered about the whole brain radiation therapy alone versus whole brain radiation therapy plus surgery. What will happen? अगर आपने सिर्फ whole brain radiation therapy दिया और साथ में surgery plus whole brain radiation therapy दिया, whole brain radiation therapy अकेले देने में overall survival was the better with surgery followed by WBRT as compared to whole brain radiation therapy. So we know that if the patient is being operated upon and then followed by radiation therapy, the outcome is better as compared to only radiation therapy. Okay, so we understand that if the patient is operable and is having a single brain metastasis, if you do surgery followed by WBRT as compared to WBRT alone, the surgical arm plus WBRT will have a better overall survival. Now, what will happen if you just choose the surgery alone? If you do not give whole brain RT after surgery, so what will happen? So this was also assessed by the Pachel et al. And they published the result in JAMA 1998. So what they found out that the surgery alone arm has a more incidence of the local recurrences. So because they are not able to control the disease at that site. So you need to add the whole brain radiation therapy after surgery. So any patient who is undergoing a surgery for brain metastasis, you need to deliver whole brain radiation therapy afterward to improve the local recurrence rate as well as the survival. So now this is the TMS data that we have analyzed for the 221 patient WBRT alone. So was done in 94% of the patients, surgery followed by post-operative WBRT in only 6% of the patient, because many of these patients will have multiple brain metastases. Very few patients will be having a 1 or 2 brain metastases, and the median overall survival, as you can see, the brain metastasis has got a dismal prognosis in real world scenario. So it's only 3.71, but we found a better overall survival in higher GPA score as expected, RPA class 1 and 2. So with the adenocarcinoma histology and when the presentation is of the synchronous type as compared to metachronous. So this is the graph of the GPA score and the synchronous versus the metachronous metastasis. Now, there was a very good article which was published in Lancet Oncology in 2016, where they have compared what if we do not want to do whole brain radiation therapy, just observe the patient with an optimal supportive care. Optimal supportive care means the best supportive care plus the steroids. What will happen? So is there any need for WBRT? Okay, so they randomize the patient between WBRT plus steroid, so versus optimal supportive care alone. So that means the steroid. So what they found out that here the primary endpoint was slightly complex. The primary outcome measure was the quality adjusted life years, called as the QALY. It is used to be generated from the overall survival and patient weekly complication of EQ5D questionnaire. Here you have seen that the GPA score, only GPA 3.5 and 2.5 to 3 was only constituted by the 17%. GPA 0 and GPA 2, so which was a lower score, which means the patient are not of a very good of a good prognostic score, was approximately 85%. So which is the real life scenario where you will have the GPA score of 0 to 2, which is not a very good score for the brain metastasis. And what they found out that there is no difference between whole brain radiation therapy versus the optimal supportive care alone. So if you find out a patient who is not doing a very good GPA score, you might just consider for the optimal supportive care steroid. You have improved the performance status. If the patient performance status is improving, then you can consider for whole brain radiation therapy. But there is a caveat to that. Obviously, if you consider each and every patient of a GPA of 0 to 2, so because the performance status rapidly changes after you give steroid. For example, if a patient is coming to this on the stretcher, and if you give a steroid for 2 or 3 days, the patient will be able to walk on its own. So it's a very difficult scenario that to consider the performance status at one time point. Okay, the performance status can change. For example, if you're given some systemic therapy or any steroid, the performance status can change from RPA 70 to 80 or 90. So it's slightly different here. So there was no difference in number of serious adverse event, no difference in quality of life or dexamethasone use, and there was obviously no significant difference in median overall survival as well as the quality adjusted life here. So from this paper, we can confirm that there is no difference between the WBRT and steroid, but the majority of the patients were of the poor prognostic score, like the GPA 0 to 2. Obviously, there was a trend toward the better overall survival favoring WBRT arm in age less than 60 years, good performance status, no extracranial met, the control primary if there are more than 5 mets, and if there is higher GPA. Now, what do you mean by short course versus long course WBRT? Whole brain radiation therapy can be delivered in 5 fraction also, like the 20 gray in 5 fraction or 30 gray in 10 fraction, or maybe more than that. Is there any difference between the short course versus the long course WBRT? For example, if you're delivering only 1 week of radiation therapy versus the 2 week of radiation therapy, is there any difference? So what this paper have shown that there is no difference in short course versus long course WBRT if you're treating multiple brain metastases. For example, if you have 10 to 15 brain metastases for a patient, whether you treat with 20 grain 5 fraction versus 30 grain 5 fraction or 10 fraction, there will be no difference in the overall survival because patient is going to behave poorly. The overall survival is not going to change, but the local control might be different. Now, what are the characteristic feature of the SRS or the stereotactic radiosurgery, which is more or less equivalent to the surgical type? So it's a very high precision technique. It's a millimeter accuracy. You will not miss a millimeter of a tumor if you are considering for the stereotactic radiosurgery. In whole brain RT, we are delivering the whole brain RT to the entire brain. So there is no point of missing the target. You will not miss the target if you are seeing like a 10 by 10 box. But if you are delivering a target, if you're delivering, for example, radiation therapy to 4 by 4 millimeter, you need to be very accurate. You need to be very precise because the chances of missing the tumor 4 by 4 mm is very high as compared to 10 by 10 centimeter box. Yeah, okay. So it should be a very high precision technique, high accuracy. The focal irradiation, the lesion size should be less than 3 centimeter, high ablative doses, 12 gray to 24 gray. If you give a 24 gray to a single point, for example, 10 centimeter, the patient can die. Okay. So you need to be very accountable for that. And it should not be delivered to more than 3 centimeter lesion. So SRS is not for all the patients. And there can be a single fraction treatment versus the multiple fraction treatment. It's a minimally invasive. There is no surgery involved. There are multiple convergent beam. It's highly conformal, and there is a rapid dose follow-up at the age of the target. Now, what will happen if you add the stereotactic radiosurgery in addition to WBRT versus the WBRT alone? So this is the first paper which was published by Andrews et al. In Lancet Oncology 2004. You can see there were 333 patients, 1 to 3 brain metastases. So the number of brain metastases were limited. It was not multiple. So they have defined that a few limited brain metastases versus multiple brain metastases. For example, 1 to 3 brain metastases. What they have done, the WBRT plus SRS versus WBRT alone. In the left-hand side of the figure, you can see the p-value is not significant. But if you consider only a solitary brain metastasis or a single brain metastasis, then your median survival has increased from 4.9 to 6.5 months. The p-value is significant. So if you're considering SRS after WBRT for a single brain metastasis, it can lead to an improvement in overall survival, but not more than 3 brain metastases or not more than 1 brain metastasis. Obviously, the GPA 3.5 to 4, the overall survival was much more as compared to WBRT alone. Now, coming to that, what will happen if you remove the WBRT? Okay, we don't want to give WBRT because it has got a very much side effect. Hair loss will be there, some neurocognitive deficit here. If there are 1 to 3 brain metastases, why not to give only SRS? It's a high-end technique. It's a fancy technique. There are big machines all over the world. So why don't you do only SRS? Why are we giving WBRT? So here is the result. So it was the first study which was published by Aoma in JAMA 2006. If you have 1 to 4 brain metastases and they all are less than 3 centimeter, if you add SRS in addition to WBRT versus only radiosurgery, so what will happen? The primary endpoint was overall survival. The overall survival is not different. Okay, overall survival is not going to be different because there are other factors into play. The extracranial disease, for example, liver metastasis, lung primary. So you need to have a better systemic therapy. You are not evaluating the systemic therapy here, but the distant brain control, where you do not have a brain metastasis at baseline, the other part of the normal lung, or I'm sorry, the other part of the normal brain will be at risk. So because stereotactic radiosurgery is a focal treatment, it is not going to treat the other areas of the brain. Whole brain radiation therapy will cover the entire brain. So you are delivering the area which are at microscopic risk for developing the brain metastasis. You are being covered with the WBRT. So the distant brain control at 1 year was much higher in WBRT arm as compared to stereotactic radiosurgery. So what does that mean? You need to follow the patient after 3 months or 6 months or 9 months or 12 months, which the repeated you have MRI. So we may not have that type of facility in India. So because there are many places where the MRI facility is not available. So what you will do? So the patient is not coming for follow-up, then you will miss the tumor which might come in at the rate of 3 months or 6 months. So if you do not have the MRI facility at your place, you better treat with whole brain radiation therapy as compared to SRS alone. The drawback of the study was there was no formal neurocognition. With respect to whole brain radiation therapy, there are reports that there might be neurocognitive decline. For example, if you have a lymphatic leukemia or the ALL patient in the children, where you deliver the PCI, prophylactic cranial irradiation, they have been shown that there are problem with the learning difficulties or speech or the neurocognition in the children. But what about the adult patient population? Because the adult brain is already developed. Okay, at the age of 2 years, our 90% of the brain is developed. So what will happen? So there was no formal neurocognition evaluation. Whole brain radiation therapy can cause neurocognitive deficit. So after surgery or SRS, if you are done the surgery or SRS, do you need WBRT? Why do we need WBRT? This is another randomized control trial. Here the primary endpoint was different. Here the primary endpoint was not overall survival. Here the primary endpoint is time to WHO performance status deterioration. So one of the example of the neurocognitive or the functional status, not the neurocognition, but the functional status. And the secondary endpoint was intracranial relapse, PFS and OS. So here they have shown that the median time to PS deterioration was 9.5 months in WBRT and 10 months versus the observation. So here the functional independence is also the same if you give WBRT or no WBRT. But the problem is that WBRT reduces the intracranial relapse, both at initial and new site. So you are controlling the brain in a better manner if you are delivering the whole brain radiation therapy as compared to focal radiation therapy alone. Focal radiation therapy or, for example, surgery. If you are delivering a focal treatment like surgery or radiosurgery versus in addition to WBRT, WBRT is slightly better with respect to control rate, but not overall survival. Here also the drawback was there was no formal neurocognition evaluation done. Now there was a randomized control trial which was published in 2009. Here the neurocognition evaluation was the primary endpoint. What is the primary endpoint? Neurocognition evaluation. The same strategy, SRS plus WBRT versus the SRS alone. Here, what they have found out that the study was stopped at the first interim analysis only. So you must have heard the start workshop in the yesterday evening, the interim analysis. More decline in memory and learning function in the WBRT arm. So there was more decline with respect to neurocognition when you are delivering whole brain radiation therapy. Okay. So WBRT is responsible for some sort of neurocognitive deficit. So the trial was stopped. So because the primary endpoint was neurocognition. Now, but if you see the freedom from CNS recurrence was higher in WBRT arm. Any recurrence in the brain was less in the whole brain radiation therapy arm, but at the cost of neurocognitive deficit. So what do you mean by neurocognitive deficit? क्या हो जाएगा अगर neurocognitive deficit हुआ तो? ऑलरेडी पेशेंट जो है अपने यहाँ पे अलग अलग लेवल के प्रोफेशंस के पेशेंट्स होते हैं. कोई इन्वेस्टमेंट बैंकर है, कोई रूरल में हाउस वाइफ है, कोई कुछ काम नहीं कर रहा है. सो वी नीड टू डिवाइड द पेशेंट, वी नीड टू ट्रैश द पेशेंट. For example, obviously the SRS is a costly treatment as compared to whole brain radiation therapy. If the patient is a 70-year-old female which is just living in a house with who is not mentally very active, she does not need to do any mathematical calculation or some finer aspect of the handwriting or something like that. You do not want to treat her with the SRS. So because it is costly and at the rural place, the MRI facility might not be available. Here, the neurocognitive deficit will not matter to that patient. So because even if she try to do the mathematical calculation like 450 plus 500, how much is that? So we'll say 950. उसको 2-3 सेकंड या 10 सेकंड ज्यादा भी लग जाएगा तो कोई फर्क नहीं पड़ने वाला उसकी क्वालिटी ऑफ लाइफ में. So we need to triage the patient with respect to the neurocognitive deficit. For example, if the patient is an investment banker, so which needs to do the calculation in a minute or like a fraction of second, there you will have the impact of the whole brain radiation therapy. Here, at the first patient, you do not need that neurocognitive evaluation. Some patients say that the memory will go away. So memory does not go away. Memory will remain intact there, but there is a definite time lag. For something to remember, you will need a certain amount of time, like 2 or 5 seconds, to process that area. And then you will remember that, oh yes, I have kept my keys in my room. Okay. Now, another randomized control trial. Here also the primary endpoint was the cognitive deterioration at the 3 months. Similar design, and then it was published by Brown et al. In JAMA 2016. So you see, we have moved from 1990s to 2016 for whole brain radiation therapy alone versus surgery alone. Now we have come to the SRS में neurocognition पे. So 1, 2, 3 brain metastasis, SRS plus WBRT versus the SRS primary endpoint is the same, cognitive deterioration. Here also you can see the less cognitive deterioration with the SRS, means more cognitive deterioration with the WBRT. The quality of life is also higher with SRS. There is no difference in the functional independence, no difference in the overall survival. It's just that the brain control rate is much better with WBRT as compared to SRS. And the time to intracranial failure was very much shorter with SRS. That means you are having an intracranial relapse with SRS. So, but the local control rate with SRS is very good. The local control rate with SRS is to the tune of 80% to 90% at the rate of 1 year. Now, post-op SRS versus WBRT. So this is the paper published by Brown et al. in the Lancet Oncology in 2017. Here, they have seen that the co-primary endpoint, it's not only the neurocognition, it is the overall survival, which is also important because this is the hardest endpoint that you need to get. And they have said that the CSF drop of greater than 1 standard deviation from baseline. Here also the same thing. There is no difference, but at the 6 month, the cognitive deterioration was less frequent in SRS than WBRT. Median overall survival is not different. SRS was not inferior to WBRT for overall survival. Now they have changed the question that they are asking. In the time that whole brain radiation therapy is superior to overall survival, what they have said is that SRS is not inferior. So if they are saying SRS is not inferior, that means they are putting it as a standard of care for the limited brain metastasis. You can do whole brain radiation therapy, but if the SRS is not showing any decline in the overall survival, it means it is more or less the same. Okay, but you need to be very cautious about that. Whenever you do SRS for any patient, you need to follow that patient up. Okay, you can't lose that patient. That you have done an SRS, go home and don't come back. Okay. Now the post-op SRS versus observation, the surgery, they have revisited the trial. As the technology has improved, they have revisited the trial, which was earlier done by Pachel et al. So this was the same trial, post-operative SRS versus observation. Here, what they have found is that the completely resected post-op SRS versus observation, the primary endpoint here is time to local recurrence. So because there is no WBRT in this arm, okay. If you see the trial design, there is no WBRT. If the patient has undergone surgery, so only observation versus the post-operative radiation therapy or the SRF. The primary endpoint was time to local recurrence at the recession cavity. The median time to local recurrence is not reached in SRS. So the local control was excellent in SRS as compared to observation. For example, that means that if you do the surgery, the 50% of the patient will have a recurrence at the surgical site at approximately 7 months. Okay, but if you do the radio surgery after you have done the surgery, the median time to local recurrence was not reached when the final result were there. Median overall survival is same. Now you see the median overall survival. We were talking about the median overall survival in 1 to 3 brain metastasis to the tune of 3 months. Now the median overall survival is 17 months. It has jumped to 5 to 6 times. But in a very selected group of population, like 1 to 4 brain metastases, obviously the systemic therapy has also played a very big role here. That paper was published in Lancet Oncology in 2017. So the systemic therapy, the chemotherapy, the targeted therapy, and the immune checkpoint inhibitor were also given to this patient. So this is the summary. For example, if you're doing an SRS, your local control will be better with SRS plus WBRT. Okay, because you're treating the focal also, and it is larger than that. So SRS versus SRT, the target is used for less than or equal to 3 centimeter lesion. The SRT is used generally for more than 3 centimeter. When the tumor size is larger, the probability of having the toxicity will be larger in a single fraction. So you need to divide the fractionation. For example, if you're doing in one fraction, you might be able to give in 3 fraction to reduce the toxicity rate. And the safety margins are different, the number of fractions are different, the immobilization device, how you immobilize the patient are different, and the optimal dose. Very high dose delivered during one treatment session versus high dose delivered over multiple treatment session. So your chances of having a radiation necrosis is less when you divide the treatment in 3 or 5 fractions. Now, Sabit, this is the single dose versus fractionated stereotactic radiotherapy for brain metastasis. There is no difference in overall survival. There is no difference in the local progression-free survival, but the toxicity were more frequently observed in the SRS group, in one fraction group. Okay, stereotactic radiosurgery is only one fraction. Stereotactic radiation therapy is in 3 or 5 fractions. So the toxicity will go down from 17% to 5%. Okay, so previously we have learned that That SRS was better, but for the larger lesion, the SRS might not be the ideal treatment. It will be the fractionated stereotactic radiation therapy. Either in delivering one fraction, you may be able to deliver in 3 or 5 fraction to just to reduce the toxicity in larger tumors. But this is the same uh, treatment regimen that the 3 gray into 9 fraction, 3 fraction into 9 gray for more than 2 centimeter lesion. The indications are larger tumor size, the critical organ at risk. For example, if you are close to the hippocampus area or a brainstem, so which are critical organ, you might be able to reduce the dose per fraction, and you can deliver in rather than 1 fraction, you can deliver in 3 or 5 fraction. Here you can see the 1-year cumulative incidence rate of radiation necrosis was nearly half, 18% for the single fraction versus 9%. Okay, so if you divide your number of fraction, if you divide the number of total dose into the number of fraction, then you will be better at reducing the toxicity in multifractionated stereotactic radiation therapy. But this is the same analysis. Now, so what is the area which is responsible for the neurocognition in brain? There can be multiple areas. It's not necessarily that this is the only area, but this is the only area which has been formally proved in scientific literature that the hippocampus is responsible for the neurocognition. So you can avoid the hippocampus. You can delineate the hippocampal area on the MRI on very thin slices of MRI, like 1 millimeter slice. It's hardly 2 cc volume. Okay, the hippocampus area, the area responsible for neurocognition, is less than 2 cc. On an average, the volume is only 2 cc. So you need to avoid that 2 cc volume to preserve the neurocognition. If you want to preserve the neurocognition, if you want to preserve the neurocognitive area, you will still have a better neurocognitive sparing when you want to. So when you are sparing the hippocampal area. Now, there are certain drugs which can reduce the neurocognitive deficit in addition to the hippocampal avoidance. For example, memantine. So here was the trial published by the Brown et al. In Neuro-Oncology 2013. 518 patients. The randomization is between whole brain radiation therapy plus memantine. So memantine can reduce the neurotoxicity, and whole brain radiation therapy plus placebo. What they have found at that, the primary endpoint is the memory as measured by the Hopkins Verbal Learning Test device. So these are the formal neurocognitive evaluation test. Okay, so this has to be procured from the US vendor. Hopkins Verbal Learning Test is the test for the neurocognition, and they showed that there was a less decline in the delayed recall in the memantine arm at 24 weeks versus only placebo. So even if you are delivering whole brain radiation therapy, if you are adding a drug called memantine, you will be able to preserve the neurocognition. So here is the alternative when you want to preserve the neurocognition in a patient, rural patient, for example. If you give the memantine, which is slightly costly as far as now, but if you give the memantine, there will be less neurocognitive decline. Now, what will happen if you preserve the hippocampal area, so which is responsible for neurocognition, and also you are delivering the memantine? Okay, so you are given 2 treatments, for example, hippocampal avoidance also plus the memantine also. Here also the primary outcome was the neurocognition, and these are the memantine doses that they have given. 518 patients here also. Median follow-up was 7.19 months. The risk of the cognitive failure was very less after hippocampal avoidance WBRT plus memantine versus WBRT plus memantine. So you see, where have you come? From the WBRT to the surgery to SRS to hippocampal avoidance WBRT. Now you have one more drug. Hippocampal avoidance WBRT plus memantine is better than whole brain radiation therapy or hippocampal avoidance WBRT alone. Now, if there are multiple brain metastases, for example, if there are multiple brain metastases and you can't do the SRS, so because of the logistical reason, financial reason, or any logistical reason, what more you can do for the local control of the lesions? Okay, for example, if there are 5 lesions or 4 lesions, you can't do the SRS for each and every lesion, for example, then what you could do? You can simultaneously integrate a higher dose, or you can simultaneously deliver higher dose with respect to the technology. Now the technology is available so that we can deliver whole brain radiation therapy, and in addition to the whole brain radiation therapy, you can simultaneously deliver extra doses to the brain metastasis lesion, so that your local control is slightly higher as compared to whole brain radiation therapy alone. So this is the local tumor control. As you can see, the blue line is of the whole brain radiation therapy alone. And if you are delivering a hippocampal awareness WBRT plus the additional dose, so your local control of the 4 brain metastatic lesion was much better if you deliver additional doses simultaneously with the WBRT. Now there's a concept of asymptomatic brain metastasis. So because we are doing the MRI at the baseline, we are doing the PET CT, which is include the CCT of brain, we are more likely to discover or find out the asymptomatic brain metastasis. The incidence obviously is less than 20%, but it is increasing now due to the routine MRI surveillance. Where we know that tyrosine kinase inhibitor have better blood-brain barrier penetration rather than chemotherapy. Chemotherapy will not penetrate into the brain, less likely to penetrate into the blood-brain barrier. But there are new generation of tyrosine kinase inhibitor like osimertinib or alectinib or lorlatinib. The question is, in asymptomatic brain metastasis, when we know that the patient is having a brain metastasis, but we do not have the report still, so with ourselves, that for the EGFR or ALK, the question is whether to deliver upfront cranial radiation therapy because there are brain metastases. We have seen that for brain metastasis, we have delivered WBRT or SRS or hippocampal awareness WBRT. Whether to give upfront cranial radiation therapy or we should wait for the report or we should wait for the tyrosine kinase inhibitor to act. So tyrosine kinase inhibitor plus cranial radiation therapy, as Dr. Nandini has already mentioned, we wait for some time and we start the tyrosine kinase inhibitor because it is much better tolerated and the safety wise as compared to chemotherapy. So the efficacy increases. The tyrosine kinase inhibitor, the blood-brain barrier penetration increases after the whole brain radiation therapy because whole brain radiation therapy itself causes the disruption of the blood-brain barrier. So the penetration rate of chemotherapy or tyrosine kinase inhibitor will be much better after you deliver the WBRT. And there is a synergistic anti-tumor effect with respect to EGFR. So EGFR is more sensitive to the radiation therapy. Now, what is the evidence for RT plus TKI in asymptomatic brain metastasis? They have shown that the radiation therapy plus the tyrosine kinase inhibitor has a longer intracranial progression-free survival. Means that the patient brain, the entire brain is very much under control when you deliver both the treatment as compared to only one treatment, or for example, the tyrosine kinase inhibitor. Upfront radiation therapy followed by TKI prolongs the overall survival. The omission of WBRT might have a negative impact on overall survival. If you omit the WBRT in the treatment paradigm, there was a study by Chen et al. Where you can see that the omission of WBRT has a negative impact. So this is the retrospective analysis, the time to intracranial progression, where you deliver only SRS or WBRT or only TKI. So what will happen? So you see the WBRT arm, the SRS and the TKI alone arm, you see the median time to intracranial progression. If you deliver the WBRT plus the TKI versus the TKI alone, your median time to intracranial progression is much better as compared to TKI. But so remember, so these are the patients who have been delivered the first generation or the second generation TKI, so which has a penetration rate of 10% or 20%, and not the third generation TKI like the osimertinib or alectinib. Now, the omission of WBRT can have a negative impact on the overall survival. And this is the list of the radiation therapy. You have studied the retrospective study where you can see the intracranial progression-free survival is much better when you combine the WBRT or any form of radiation therapy with respect to TKI as compared to TKI alone. Now, there is a meta-analysis also of all the retrospective and prospective study, which has also shown that it favors the whole brain radiation therapy or any form of radiation therapy in addition to TKI versus the TKI alone. But these are the first or the second generation TKI. We are not talking about the osimertinib or alectinib here. This is the only randomized control trial where they have compared the tyrosine kinase inhibitor in driver mutated population versus the whole brain radiation therapy. But there is a caveat here that in the driver mutated population, they have not delivered the TKI. They have delivered the chemotherapy. So if you are not delivering a tyrosine kinase inhibitor in the driver mutation population, it's not ethical as of now. So this is the flawed randomized control trial where you have seen the TKI alone versus WBRT plus chemo. And you can see that there is no difference in the overall survival or in the intracranial progression-free survival was much better in the icotinib arms. So because you haven't delivered the icotinib in the WBRT arm. Now, asymptomatic. So these are the asymptomatic brain metastasis because if you see the randomized control trial between the TKI and the chemotherapy, they have allowed the asymptomatic brain metastasis when they are controlled or when the WBRT has already been delivered. So you can see the lung, lux lung 3, lux lung 6 and 7, the aura and the flora. The it is the median progression-free survival is approximately 10 to 11 months. Okay. So now what are the issues with the delayed cranial artery? The issues are the brain metastasis is a dreaded complication and it might be difficult to control. If you deliver geftinib and if the patient progresses on geftinib, it might be difficult to salvage the treatment. May serve as the focus of the disease settling. So because the penetration rate of tyrosine kinase inhibitor are not so great, especially of the first generation or second generation, it may act as a focus of the disease seeding. And the decline in performance status and subsequent quality of life, the possibility of not getting a salvage treatment. If the patient has a drop in the PS and is not able to come to the hospital, you might not be able to salvage the treatment. And the MRI surveillance is required to do the proper MRI surveillance. If you are not delivering any type of radiation therapy, the added cost of the MRI, the patient anxiety and the physician anxiety. So this is the randomized control trial that we are doing at Tata Memorial Hospital to sort out this issue, whether we should delay the cranial radiation therapy or whether you should offer the upfront cranial radiation therapy. Here, we are only seeing the asymptomatic brain metastasis. For symptomatic brain metastasis, there is no doubt that you need to provide the symptom relief. And how will you provide the symptom relief? With respect to steroid plus the radiation therapy. But if the patient is asymptomatic and if the patient is driver mutation positive, whether we should offer upfront cranial radiation therapy or whether we should offer a delayed cranial radiation therapy at the time of progression. So this is the randomized control trial. It is ongoing. So with this, I would like to thank the organizer for giving me this opportunity. If there are any questions, I'll be happy to answer. Yes, please.
Do we still give RT to symptomatic patients, or we will wait?
So yeah, this is there is no clear answer to that. We know that the osimertinib and alectinib and lorlatinib, for example, have a better blood-brain barrier penetration. It depends upon the location of the brain metastasis lesion. For example, if the lesion is in the eloquent cortex, for example, the precentral gyrus, we might not be able to save the patient if the patient is so become symptomatic, for example, left unilateral limb weakness or right-sided limb weakness. But at the same time, you can question that if you deliver the radiation therapy, there are more high likelihood that the patient will develop the edema and the patient may become symptomatic. So it's on the other way. So that's why we have started this randomized control trial to answer that question, because it will be very individualistic. You will have to speak to the patient. So whether he wants to wait for the tyrosine kinase inhibitor to act upon, or whether he wants an upfront treatment with respect to radiation therapy. Because if you omit the radiation therapy, you are doing a legal issue. Because now, as of now, the standard treatment for the brain metastasis is either surgery or radiation therapy. If you're not offering the patient surgery or any radiation therapy, then you need to counsel the patient. You need to document everything that we have explained to the patient, and the patient is willing for observation as far as the TK is concerned, and you need to repeat the MRI. If the patient is controlled, then you may continue osimertinib or alectinib. Okay, so it's a slightly tricky question to answer as of now.
And sir, when we request for hippocampal sparing WRT, does it add anything logistically to the RT team, or it's just a design?
No, it's add to a very logistical support. It's a very technically challenging procedure. It's not a fancy design. You need to spare like an island. आप एक आइलैंड पे बैठे हो, चारों तरफ में समंदर है, आपको वो एरिया को बचाना है, बाकी पूरे समंदर को डोज देना है. So it's a very technically challenging procedure. It requires is the same. The doses are the same, but it's a very technically challenging, and it should be delivered on. It can be delivered only with respect to IMRT or VMAT. It cannot be delivered with the telecobalt. Okay.
So it adds to the cost.
Yeah, it adds to the cost. Any other question? Okay, thank you very much.